As I said, what I'm going to be talking about today is vaccine hesitancy and COVID-19 misinformation. Before we get underway though, I'll begin by acknowledging the traditional owners. So the Queensland University of Technology acknowledges the Turrbal and Yagara as the First Nation owners of the lands where Kiiti now stands. We pay respect to their elders, laws, customs and creation spirits. We recognise that these lands have always been places of teaching, research and learning. Kiiti acknowledges the important role Aboriginal and Torres Strait Islander people play within the Kiiti community. So I thought I'd begin by way of an overview. So I'm going to start off today by defining what vaccine hesitancy actually means. And for a term that is so frequently used, you'll be forgiven for assuming that there is consensus, and there's not. I'm then going to talk about vaccine hesitancy in a broader context, and that broader context is the contribution it makes to what I would call suboptimal vaccination. And so I would use this as an umbrella term to describe partial vaccination, non-vaccination, and delayed vaccination, all of which are problematic. I'll then turn to the relationship between misinformation and vaccine hesitancy. I'll turn to existing interventions that can be used to try and combat this issue of misinformation and how it contributes to vaccine hesitancy. And then finally, I'm going to deal briefly with one of the key objections that are raised to what it is that I'm going to be saying. So the definition I've provided on the screen here is the prevailing view of what vaccine hesitancy is. And this comes from the Strategic Advisory Group of experts who are a part of the World Health Organization, and they were convened together to come up with a definition for vaccine hesitancy. What is this term? And the definition that they come up with is vaccine hesitancy is a behavioural phenomenon that is vaccine and context specific and measured against an expectation of reaching a specific vaccination goal given the immunisation services available. So the key term there, which I've underlined for all of you, is that they're asserting that it is a behavioural phenomenon. Today I'm going to offer you an alternative perspective of what vaccine hesitancy is. The act of refusing or delaying vaccination is a behavioural phenomenon. That act is a behaviour. Vaccine hesitancy is a mental state that can lead someone to act in that way. But the mental state and the behaviour are distinct. And we can see this distinction exists because when a person is vaccine hesitant, that hesitancy is not tied to a particular action. And there are 3 articles that show this, which were published by Hull et al., Trent et al., and Armiento et al. And in each article, they showed that the no jab, no play interventions that were implemented were able to promote vaccination uptake, but they did not necessarily change an individual's views on vaccination. So that is to say, while the individuals agreed to be vaccinated because they wanted to avoid the various difficulties that arose if they weren't vaccinated, they nevertheless still felt hesitant about vaccination. Now, you might respond to that observation by saying, does that really matter? Provided the people are vaccinated, does it really matter that they remain hesitant? Because after all, if a person is vaccinated, they're still contributing to herd immunity and they're still protected against the vaccine-preventable disease. So I would challenge that response by saying, if you focus on the behaviour and not the mental state, you are focusing on the consequence of the problem and not the problem itself. And this is problematic because if you are only focusing on addressing the consequence of the problem, you create a situation wherein you're in this never-ending battle. The person's views don't change. And so public health and protecting public health is always going to be dependent on restricting their liberty to some degree in order to get them to do something that they don't want to do. A necessary or an inherent consequence of taking that approach is that you also need to lean on restrictive measures that utilise manipulation and coercion, things like the no jab, no play and no jab, no pay policies, because you're trying to get someone to do something that they don't want to do. And so a better approach that I'm going to be discussing today, or at least a less restrictive approach, is to try and change that individual's mental state so that they are no longer so averse to being vaccinated. With that understanding of vaccine hesitancy, I now want to talk a little bit about the broader context. And quite often in the media and when lay people are discussing this issue, people tend to conflate vaccine hesitancy with non-vaccination. as if to say that the only reason someone is not vaccinated is because they're hesitant about vaccination. And this is a misconception, it's not accurate. So there was quite an interesting article that was published by Thompson et al., and they identified 5 different causes of suboptimal vaccination. So 5 different reasons a person won't be vaccinated, or that they'll delay vaccination, or that they'll be partially vaccinated. And those reasons are outlined there. Obviously, we have vaccine hesitancy, which we've just discussed. Accessibility is an issue that we will all likely be familiar with now. As we had the vaccine rollout in Australia at the beginning of this pandemic, not everyone was able to access those vaccines immediately. Affordability is also an issue, and it would be easy to think that it is not an issue in Australia because many of the vaccines available to us are available for free. But affordability also refers to the opportunity cost that comes with taking the time to go to a hospital and get vaccinated. So if someone works every day, or if they have other commitments in life, they're raising children and things like that, there is a cost there. And particularly if you live in remote communities where it may be less convenient, perhaps you don't own a car, for example, that can be quite a significant cost for some individuals. Awareness is another issue that arises here. And so awareness refers to a person's knowledge of not only that vaccines exist and that they're available to them, but also the knowledge that they are beneficial and that they're safe and they're readily available and where they're available from. The 5th cause that Thompson et al. Identified is activation. And the way that they have defined this is it is the degree to which individuals are nudged towards vaccination uptake. So what they're talking about there are nudging interventions, which I'm sure many of you have heard about before, and certainly was discussed at length by Thaler in their famous book, Nudge. And it's that intervention that I just want to focus on for a little bit here. So when we talk about nudging, what we're talking about here is presenting a series of options in a way that is going to make that person's choice more predictable. The better view is that nudging, or the absence of nudging interventions, is not itself a cause of suboptimal vaccination. This is actually a determinant of vaccination uptake. The reason that the authors have arrived at this position where they say the absence of nudging is a cause is because they have used the word determinant and cause as synonyms in their articles. But these terms are not synonymous, and there is an important distinction between them. So you can see I've provided the definitions there. When we talk about a determinant, we're talking about a factor that decisively affects the nature or outcome of something. When we're talking about a cause, we're talking about something that gives rise to that outcome. So the way the authors approach this is they began by asserting that nudges are a determinant of vaccination uptake, and they're quite right in saying that. Certainly in the book, Nudge, there's a wealth of information in there that shows that if you nudge people, you can prompt them to do certain things. And there has subsequently been many articles that have shown that nudging in the context of vaccination can prompt people to agree to be vaccinated. There was one article in particular where a doctor ran a study where he said to some patients, "Would you like to be vaccinated?" And when he afforded them the choice, they were less likely to be vaccinated than if he phrased it as, "Well, now it's time to be vaccinated." So not giving that individual the choice nudged them to simply go along and agree to be vaccinated. So they're quite right. Nudging is a determinant of vaccination uptake. It does not follow, though, that the absence of nudging is a cause of suboptimal vaccination. And this can be shown by way of an analogy. It is well established in public health that the provision of healthcare services is a determinant of positive health outcomes. It is a determinant of positive health outcomes because healthcare services can mitigate the impact that disease and injury has on a population. But it doesn't follow that the absence of healthcare services cause those negative health outcomes. Rather, it enables the true causes, which are disease and injury, to impact a population in a way that is unmitigated. Similarly, in the context of vaccination, the absence of a nudge does not cause people to not be vaccinated. Rather, it enables the other 4 causes to impact the population in a way that is unmitigated. And so the better view here is that there are in fact 4 causes of suboptimal vaccination. So with our understanding of vaccination and context in which it sits, so knowing that it is not the only cause of suboptimal vaccination. I want to talk now a little bit about the relationship between misinformation and vaccine hesitancy. So I'm going to preface this by saying that the sheer number of articles on this particular topic is so vast and varied that it's impractical to compile an exhaustive list. So what I have put forth here is a sample that I think does a good job of showing that this relationship exists, but is by no means exhaustive. And the way that I'm going to approach showing that this relationship exists is first to establish that people seek out health information online, second, that there is misinformation online, and third, when people are exposed to that misinformation online, they are less likely to agree to be vaccinated. So beginning with our first point, people use the internet to access health information. I'm going to rattle off a few different articles here and the key takeaways from these articles. So Bradshaw in 2019 found that first-time mothers have been shown to embrace social networking sites such as Facebook during pregnancy in order to develop social support and network building to strengthen their ties so that they can trust the health information that is delivered to them. A report by Donzelli in 2018 showed that 42.8% of Italian citizens use the internet to obtain vaccine information. The Pew Research Center found that 77% of Americans search for health information online. In a study involving 14,956 participants, which was representative of 7 European countries, Kermode et al. Found that 52.2% of citizens in that study use the internet for health purposes. So certainly there is evidence to indicate that people access the internet when they're trying to find information about health-related issues. And I think we can probably all relate to that. Certainly, if I get a niggling pain in my shoulder, I jump straight onto WebMD and convince myself that I'm going to die tomorrow. So I think that, it's reasonable to say this is something that we all do. So then we can turn to the issue of, is there misinformation online? Is this really the case? Or is this something everyone keeps talking about and it's not actually problematic? It is problematic. And so again, to turn to a few studies here. The Center for Countering Digital Hate in 2020 found that 400 anti-vax media accounts contain 58 million followers, and those followers are based primarily in Australia, the US, the UK, and Canada. Between 2019 and 2020, social media accounts that oppose vaccination accumulated an additional 7.8 million followers. As of 2020, 31 million people follow such accounts on Facebook, and 17 million people are subscribed to such accounts on YouTube, according to a study by Berkey in 2020. Misinformation about COVID-19 was sufficiently prevalent in 2020 that the World Health Organization launched a Stop the Spread campaign, and they're talking about the spread of misinformation, not COVID-19, and they did so in partnership with the UK. On Facebook, anti-vaccination content consistently receives more attention, likes, and shares, according to a study by Covello et al. In 2017. And numerous organizations and websites online are dedicated to opposing vaccinations. And these include Safe Minds, Generation Rescue, Age of Autism, the National Vaccine Information Centre, the Canadian-based Vaccination Risk Awareness Network, the Australian Vaccination Network, Natural News, Macalo News, Mothering.com. These organisations present themselves as neutral watchdogs, so they don't openly say, we are anti-vax, rarely will they use that term. Instead, they pose themselves as objective providers of information. They also have a presence in the media. So historically in the past, they've taken out full-page ads in newspapers to advertise their organisations and the kind of information that they can provide to individuals. And another point that I want to flag here, which I've often found in talking to people, is you mentioned these websites, and people are of the view that these are obscure websites that perhaps don't get much traffic, not many people know about them, they're very niche in corners of the web that no one really visits. That is not the case. So in a study by Carter et al., they found that Mothering.com alone received 1.5 million unique visitors every month and was ranked as the most active online community for parents. And this is an organisation, this is a website that produces misinformation about vaccinations. The issue also arises in respect of search engines. So in a study by Davies et al., they undertook a search of the term vaccination on 7 different search engines, including Google. And they found that 43% of the results that were returned were for anti-vaccination websites. 43%. So we know that there is misinformation on the web, and we know people are visiting the web to try and find out information about their health. So if someone is exposed to this misinformation, does it have an impact on them? Does it influence them to make a decision about whether or not they're going to be vaccinated? In a study conducted by Wilson and Weishaupt, the authors found that the prevalence of foreign disinformation is highly statistically and substantively significant in predicting a drop in mean vaccination coverage over time. This is a study from 2021. In a study conducted by Jennings et al. In 2021 again, the authors found that individuals who obtain information from relatively unregulated social media sources, such as YouTube, are less likely to become willing to be vaccinated. In a 2020 study by Charon, involving 3,938 participants, the authors found that obtaining vaccination information negatively impacted the vaccination acceptance rate of those people. Evidence of a causal link between the spread of misinformation and a reduction in childhood immunisation was produced by Carreri et al. In Italy by studying the rate of immunisation before and after misinformation about the MMR vaccine went viral. And in a 2017 study by Dunn et al., the authors found that the vaccination coverage was lower in US states where people were more frequently exposed to misinformation about vaccines. And this lower rate was not accounted for by socioeconomic factors. So we can see that there is at least some evidence out there to say that when people are searching for information about their health online and they're exposed to misinformation, that they may be less likely to be vaccinated. So what should we do about this? There are many, many interventions that are available to a government to try and promote vaccination uptake. I've listed, again, not an exhaustive list, but I've listed several here. Excluding the ones with asterisks next to them, those interventions are listed in order of least to most restrictive, and that is a list of interventions that comes from a book called The Ethics of Vaccination, which was written by Alberto Giuliani in 2018. And he's provided quite an exhaustive list spelling out exactly why each intervention is more restrictive than the next. There are many ways in which these interventions can be grouped together. I'm going to group them together in terms of interventions that target the information environment in which we exist and interventions that target the individual themselves. Now, I've already highlighted at the beginning of this presentation why it can be problematic to simply try and manipulate and coerce a person. Because if you do that, you are targeting the consequence of the issue, not the issue itself. And so I don't want to focus today on manipulating and coercing human behaviour. I instead want to talk about altering the information environment. When I talk about altering the information environment, what I'm talking about here is the dissemination of information, promoting the dissemination of information, and also restricting the dissemination of that information, and the kinds of information you want to promote and restrict. And so you can see I've got 3 interventions there, and I'm going to talk about each in turn. Persuasion is most commonly represented by an education campaign. So that's what we're all familiar with, and Australia does quite a good job of that. If you Google something like vaccination, is it safe? You'll be presented with a number of government websites that, in my opinion, provide you with some quite comprehensive, easy-to-read information about why vaccines are safe. A common criticism of persuasion is that it's not enough. It doesn't do enough. We have all these education campaigns, we've had them since the start of the pandemic, and yet clearly there were still a lot of people who were hesitant about vaccines. And so people can have this tendency to think, well, the education campaign didn't work, so now we're going to focus on the individual and we're going to coerce them and make their life really hard until they do what we want them to do, because they're not going to listen to reason. So persuasion is quite an effective measure when ignorance is the cause of a person's hesitancy. So if a person simply doesn't know about the benefits of vaccines and you educate them on those benefits, then it will be quite persuasive and that person will be inclined to go and get vaccinated. But ignorance is not the only cause of vaccine hesitancy. A separate cause is uncertainty. So if you live in an information environment that is filled with information, but is also flooded with disinformation, those differing views become intermingled. And I like to use an analogy to demonstrate how this creates uncertainty. Imagine you're in a hospital and you have two doctors beside your bed. And the first doctor tells you, you need to undertake this course of treatment, it's going to be very beneficial for your health, absolutely should do it. And as that doctor is saying that, the doctor beside him is saying, absolutely do not undertake that course of treatment. You might die, you might be really harmed, that's a terrible thing. If you're the patient and you don't actually have an expert knowledge of that treatment yourself, you'll be forgiven for being left uncertain as to what course of action you should believe. And it is a reasonable analogy because when you look at the people who are most influential in disseminating disinformation about vaccination, several of those people are in fact doctors. And you can find a list of those people in a report that was published called The Disinformation Dozen. Several of the people on there are doctors. So for a layperson, you may have a doctor telling you, well, absolutely you should be vaccinated. But then you have these very influential doctors that have a wide reach on social media saying, no, you absolutely shouldn't. And so that creates uncertainty. Now, persuasion, as I said, is very effective at combating ignorance. But if a person is uncertain, simply flooding them with more information in no way changes the disinformation that they are also being exposed to. And so a different measure is needed there. And there are two ways to go about this. The first and most obvious is censorship. And this is certainly an approach that was adopted in Singapore. They have legislation in place where they do censor the dissemination of falsehoods online. There is a great deal of criticism of that approach. A lot of people have concerns about things like free speech. And I would also raise an additional concern in that, to some degree, the boat has sailed. So that misinformation is out there, and even if you start moving it now, it has already touched people's lives, and there's nothing you can do to stop those people talking offline or talking in private messages, sharing that kind of information. So it's not to say that censorship doesn't have a role, and it can take many forms. Some people advocate for simply deplatforming. So that's to say, you can say whatever you want, but we're not going to provide you with a platform on which to say it. Or we're not going to provide you with a platform that gives you a wide reach on which to say it. And so there is room to have conversations about whether or not that's appropriate. But an alternative approach that I would like to discuss is the promotion of health literacy. So when we talk about health literacy, what we're talking about is a person's capacity to locate information that's distinct from disinformation, and to be able to distinguish information from disinformation, and to be able to understand that information. So this gives someone the tools to be able to make an informed decision without being misled, or being misled to a lesser degree by misinformation. And there are a number of interesting studies that have come out in the last year that have shown that given the right approach, you can effectively teach people health literacy. And so that offers an alternative approach that is not going to restrict an individual's liberty, which might put them in a good position to be able to distinguish between information and disinformation. Now, some of you may be sitting there and you may be thinking to yourselves, that sounds lovely. And it's a very altruistic approach, and we would all love not to infringe on a person's liberty and resolve this issue, but frankly, it's not going to be enough. Some people are not going to engage with those kinds of resources, and if a person doesn't engage with a resource designed to teach someone health literacy, they're not going to be health literate. And that is a fair criticism. So I want to couch what I've said today in these terms. I am not suggesting that if you teach people health literacy, you are going to achieve some undefined goal. The objection that a particular approach is insufficient could be raised in respect of any intervention if you don't specify the goal. Okay? You could say, for example, mandatory vaccination is not sufficient if, for example, you think the entire population needs to be vaccinated. And certainly there are some authoritative commentators who do think the whole population needs to be vaccinated, like Alberto Giubilini. Even if you identify the goal, though, and health literacy falls short of that goal, it does not mean that it has no value, because there is good reason to think that it will be effective for some portion of the population. And if you subsequently have to implement more restrictive interventions to convince others, it is still worthwhile to promote health literacy first, because you are able to get those people vaccinated without restricting their liberty. And so that is a less restrictive option. And per the principle of least restrictive alternative, it should be preferred to jumping at first instance to something like mandatory vaccination. So they're the key points I really wanted to touch on in this presentation, and I have this very long bibliography, which quite happy to send anyone sources if they want any. There you go, still goes. But that's it for me.